is Laura Odom. I'm a nurse practitioner and professor at the University of Tennessee College of Nursing in Knoxville. So I suspect I may be one of the people that came the least, I didn't have to come as far as everyone else who traveled today. I recently finished my doctorate from Vanderbilt University, and I developed a mobile phone application, thank you, for use with adolescents to help with asthma. Just out of curiosity, how many people in here treat asthma patients? Almost everyone. I know, because I know we have a wide variety of specialty practices. The challenge that I face, I've worked in allergy immunology for the last 12 years, and what I find in practice is we do a really, really phenomenal job of diagnosing patients. We do a really, really great job of treating patients and giving them the right medication, but then they don't know what to do when they're having an exacerbation. They go and, they take the wrong inhaler, they don't take their maintenance inhalers, they end up in the emergency room when probably using their rescue inhaler at home might have been a better alternative. So what we looked at least in the United States, the incidence of asthma is increasing by 15% over the last decade, which is pretty remarkable, really. We continue to do a great job with biologic agents. There's new medications out there. There's no reason, really, why we can't treat the vast majority of asthma patients. So why do we continue to have increased exacerbation rates and increased prevalence of asthma? Well, the way that we treat asthma right now is that we have written action plans. How many of you guys give your patients written action plans? What is the very first thing that everybody does when a medical provider hands them a piece of paper? They fold it in half and do what with it? Who knows? Best case scenario, it ends up in your purse, right? Best case scenario. Worst case scenario, it ends up in the office. I can't tell you how many times I go in to see the next patient, and there sits my written plan of care that we so beautifully described in the exam room. So, what can we do about that? Well, you all know the burden of asthma. The death rate among children, interestingly, under the age of 19 has increased by 80% since 1980. I find that alarming, and I think that we can do a better job with that. In 2011, 3 out of 5 kids with asthma had recurrent asthma symptoms. So not only are these patients suffering, but they're having recurrent symptoms. So when you think about their quality of life, the economic burden, what this means, $56 billion cost just in the United States. And I know we have a global representation here, so I can only imagine how this impacts the rest of the world. Quality of life. 2 million ER visits each year. I've seen studies that talk about in the pediatric population that almost 1 out of 4 kids seen in the ER has some kind of asthma diagnosis tagged with it. That's a lot. All right. 2/3 of deaths from asthma are completely preventable. This just came out in the British Medical Journal just this past year, and it talked about the ways that we can prevent deaths. One of the big ones was to make sure we're adhering to guidelines. Well, I'd like to think that we adhere to guidelines. But if we don't properly diagnose these patients with the level of severity and educate them on how they can control their asthma, we're not really adhering to guidelines. Written action plans were talked about it. In my practice, we did a retrospective analysis. We randomly pulled over 1,000 patients who had been diagnosed with asthma. And I work in an allergy immunology practice. We should be really good about giving written action plans, right? Less than 1.4% of our patients had a written action plan documented in the chart. Now, that's not to say we weren't educating them. That's not to say that we weren't using them, but less than 2% of patients had a written plan of care. Most of the literature says that time is the reason we don't do that. None of us have enough time. So this was, I apologize for the doctoral work. I have to put in my little plugs as far as how we developed this, but the asthma burden and how that's defined. You can see all the different things that play into asthma burden and why it's such a problem. So you've got the severity of disease, hospitalizations, morbidity, mortality, all those kinds of things. We use social cognitive theory looking at how can we best impact our patients, and we're thinking about changing behavior. So there's lots of things that go into changing behavior. There's environmental influences, there's behavioral factors, there's personal factors, there's social stigma. Are adolescents afraid to use their inhalers because they believe that they will be viewed as weak, or they will be viewed as having something that their peers don't have? So what can we do to try to improve that? Well, how many people in here right now have their cell phone within arm's reach? Have a smartphone that they could pick up? How many people have been on their smartphone since we've been in here this morning? I know I have. So we did some research, and we found, at least in the U.S., that 77% of adolescents aged 12 to 17 own a mobile phone. 87% of older adolescents aged 14 to 17 years had a mobile phone. So they've all got phones. So if they've got something with them all the time, are they going to have that written plan of care with them when they need it? No. Will they have their cell phone? Probably. So here's a couple of examples of some written plans of care. So this is confusing for patients. When we give them these big, long instructions and we expect them to either memorize this information or be able to glance at it and understand what's going on. How many of you guys have heard of the chunking principle? Has anyone heard of Miller's chunking principle? So Miller's chunking principle has to do with the amount of information that an individual can retain and understand at any given time. And they talk about 7 bits of data. So people can remember 7 bits of data. How long is a phone number? 7 digits. So we can remember that. We can retain that information. Are there more than 7 bits of data on these written plans of care? 7 million, yes. So there's a few more than 7 bits of data on this particular plan of care. So here's what we did. We took this and transformed it. These are this is the workflow. These are our screenshots. And we essentially took a written plan of care and chunked it into data that made sense for the patients. So let's walk through it. This is the home page. Now again, we designed this for the pediatric population. So this is for a child or a parent, but just to make it visually engaging and make it really clear and simple to understand. For those of you that treat a lot of asthma patients, do you use peak flow meters much? Bingo, yes. So here's my personal take on peak flow meters. I find that in this particular age population, they tend to abuse their peak flow meters. I think of it as like the thermometer on the light bulb sort of thing. You know, oh, my peak flow is 200 today. I can't breathe, Mom. I don't want to go to school. So I tend to reserve my peak flow meters for people that I believe will use them as they're intended as a way to measure their breathing. So in kids, I don't use them as often. I base it a little bit more on symptoms. So we've got, how are you feeling? You can put in your peak flow, if you know your peak flow, and it will guide you and take you to the correct zone of control. Or you can click on each one of these things. So when patients download this app in the office, the provider or the nursing staff will walk them through their action plan. So you get 2 for 1. You get education and then guaranteed access, because you know it's going to be on their phone. So that written piece of paper that you gave them does not get folded up and stuck in the bottom of the purse. It's on their phone. So you log in, they put in their information, so they're going to be tagged to the provider, the specific provider. You can put in triggers. So if you're in an allergy practice in particular and you know what triggers these patients' asthma, you can put that information in there so that they're aware. And this is also a really great cue to be able to educate the patients and say, hey, you know, did you know that cigarette smoke triggers your asthma? And just that one little line so that they're aware that this is what's going on. Okay, Hilton, I don't need internet. Peak flow, you put in your personal best peak flow if you know your personal best peak flow. So that way it'll be able to calculate on the back end your ranges for the yellow, red, and green zone. You put in your medications. So this for new practitioners, for new providers that maybe aren't entirely comfortable with managing asthma for nurses, this is a really good education tool for them as well. In the green zone, you only have controller medications. In the yellow zone, you only have rescue medications. So it's a way to kind of simplify the process for both the patient and the provider and make things easy. Once they have their medications input, when you go to good to go, there aren't any controller medicines listed because this was just in the development phase when I took these screenshots. But under controller medications, it will list what you're supposed to be taking. So on a daily basis, if you go in, you measure your peak flow, and it takes you to the green zone or the yellow zone or whatever, it will tell you exactly what medicine to take. You can call 911 or you can call your provider's office directly from the app. So if you're having trouble and you need help, you can call the provider. And then here's the home page again. So when we were developing this, we did conduct a really brief, just in a feedback evaluation survey to find out, do patients, do they like this? Do they feel that this would be helpful? Do they, think that this is something that they might use? And here was our survey. We said, what is your familiarity with using apps? Did you find the Asthma Action Plan app easy to use? Can you use it without written instructions? Because that's very important. Can you follow these steps without having to have a written piece of paper telling you how to use it? Does the app do everything you expect it to? It's designed for adolescents with asthma of any severity. And does it help me understand what to do in the event of an asthma attack? And what we found was yes to most, those answers. We didn't have anyone disagree with that. The results were quite good from these few results. The key comments, they loved that it was portable. They loved they could call 911 in the office from the phone. I think my mom would like it a lot. I got a lot of feedback from parents saying, this gives me some peace of mind knowing if I can't be there that my child would know what to do in the event of an asthma exacerbation. I got one patient tell me, I would use this much more than my paper copy. I don't even know where that is. I think my mom would feel better if I had this. And then some of our providers had some things to talk about as far as ways to communicate with the practice, and we have fixed that. So the patient feedback focused on the user interface. They loved it. They thought it was great. It was easy to use. They could understand it. The kids could play with it without any trouble. Even some of my really little kids had no trouble getting in there and understanding it. The providers focused on efficiency. They were worried, is this going to take time away from my patient care? Is this going to be extremely time-consuming to have to deal with? And then how was the app going to communicate with the providers? So we took that feedback, and we've now developed a web portal. So the app information is actually accessible on a web portal, so providers can additionally, they can track their patients' peak flows. They can track their patients' medications and all of that. So there is a way to there is a way that the app communicates with providers. So that was something that we addressed after designing the application itself. The strengths of this, it improves access for patient care. It simplifies asthma care. HIPAA compliance is something that we are battling at the moment because there is some personal health information here. So we've been having to jump through those hurdles. And then transferring the mobile phone information to EMR. How many of you guys use EMR systems? Okay. And then survey participants were my patients, and so I'm sure that there were certainly some bias with that when we were doing these survey results. We're hoping to use this certainly in allergy immunology practices, in pulmonary practices, pediatricians' offices, that kind of thing. I would love to see this be able to be implemented in an emergency department setting so that when patients are discharged from the emergency room, they have this as a way to keep them out of the emergency room and a way to keep them from having to be right back in there. I think this could be used for research purposes because you have such an enormous amount of data. You could crowdsource this in a way and be able to track exacerbation rates and track air quality and link it with the action plan and that kind of thing. And then I think certainly this application, you could use an app like this for other chronic disease models. I think that that would be effective in other chronic diseases. Does anyone have any questions? Yeah.
So do you
Yes. Well, that's a great question. So one of the things that we looked at in the app was using the ACT score as a way to track, if you're familiar with the ACT score. We put that in the application as a way for patients to measure once a month that they would track their asthma control. And there would be a push notification that said, hey, you need to track your asthma control. We ended up finding out that the ACT score, you can't just use it electronically. You can use it in paper form, but you can't use it electronically without getting a license agreement. So we worked with the Quad AI, the American Academy of Allergy, Asthma, Immunology, to develop an alternative score. It's called the CAST score, and it's a four questions that talks about your asthma control within the week, and instead of measuring asthma control over the month, it actually helps to point you to whether you're in the red zone, yellow zone, green zone for that given week. So if you have somebody that doesn't use peak flows and you want them to be able to know, are they in the red zone, yellow zone, green zone, they can answer those four questions, or mom can answer those four questions and then point them to what they need to do.
The other question is the difference between asthma and bronchitis.
The wheezy bronchitis kind of stuff, yeah. Well, I mean, so diagnosing asthma in little kids is especially hard because, of course, the gold standard is that you'd have a 12% improvement in FEV1. Well, if you have a 2 or 3-year-old child who can't adequately perform a pulmonary function test, how are you going to demonstrate reversibility post-bronchodilator treatment? So that, yes, that's definitely a challenge in the emergency room or any setting. I think, clinical history can help predict that one, yeah. Mm-hmm. Yeah. So the app is, if people want this app, it is something that, come talk to me, because it is something that could be available to anyone. We just have to figure out a way to make sure that that practice has access to the web portal so that you could use it. But yeah, definitely. Yes.
Have you tried to apply this application in the ER settings? I understand you work in a clinic, but the ED has a different challenge in terms of treating your patients and also giving these asthma action plans.
So
have you communicated to your colleagues in the
Yes. So we've met with both Vanderbilt Children's Hospital and the Knoxville Children's Hospital to talk about how they might be able to implement this app in the ED. The problem is these are not patients that are followed long term. You treat them and send them on their way. And so we're actually trying to work with the state of Tennessee to try to implement a system where there could be a registry of sorts. And this would be something where patients would be linked into that. But that's where HIPAA gets a little bit sticky. There's some privacy concerns. So you have to figure out a way to have these patients identifiable to the emergency department, but not identifiable to other practices in order to protect their privacy.
New York has this system called RIO, where actually you can, through the electronic medical record, you can communicate with other type of settings, other hospitals. And as you mentioned about the registry, that might be a way actually
It would be.
Go through the patients and get
It would be, yeah. And that's in New York, you said?
That's in New York.
Okay. Did I see one more question? Yes.
Would the app allow real-time feedback to the attending?
It would. Yeah, so the nice thing about this app, because there are other asthma action plan apps on the market that exist. The difference between the ones that are on the market and this one is that there's that web portal. There's that provider feedback piece that tracks the information. So every time a patient goes into the app and accesses it in some way, whether it's to measure their peak flow, whether it's to take the CAST score, which there's a weekly reminder for them to do that, that information is going to be sent to the provider. And in the web portal, when you look up these patients, if you are a provider and let's say you have 30 patients that are using this application, it will actually say 24 out of 30 of your patients are in the green zone right now. And you can go in and click and say, well, who's not in the green zone? and what's going on, and have they logged in recently. And so there's a way, I mean, you could go in, the way I anticipate, the way that I hope that this will be used in our practice, is that every morning when you get to the office, you would briefly check in, and click, or get staff, nursing staff, if you have nurses that could do that, and look at the portal and say, okay, we've got, 2 patients that are in the red zone. Maybe we need to reach out to them today. Let's try to keep them, maybe a phone call, bring them in for an office visit, something that you could, because ultimately the goal is to keep them from having a bad outcome, clearly, but we want to keep them out of the emergency department. I think if we can manage them, because you're talking about, between just the quality of life issues, the missed work time, the missed school time, the economic burden that faces, and at least in Tennessee, many of our patients that end up in the emergency room with asthma are Medicaid patients. And so the tax burden to the entire system is huge when they end up in the ER. The average cost of an ER visit for asthma is about $1,500. So, and that's the average cost. That clearly you can have a lot more than that. So I think that there definitely is a need for something like this, and I think the key is having that provider interaction. Because if you give the patient the app and they have it, that's wonderful, but if there's no accountability, if the patient doesn't know, oh, my doc is actually keeping tabs on this, they know that I'm using it or know that I'm not using it, I think that just adds another element and helps to keep them accountable.
Do you think that you can work in the third world countries?
Don't you think what? I'm sorry.
Perspective and feasibility in the third world countries about this plan? With the health
That's a great question.
Right.
It would be wonderful, but I don't know do people have phones? Well, for those of you that came from not the United States, I would love to hear kind of your thoughts on if you think something like this would work in that environment.
I believe nowadays with internet, with all the electronic type of access through the world, basically having a communication electronically, that'll be it. In fact, many of the rates are much cheaper probably in other parts of the world comparing with what we have here. So
That's
having that
interesting.
access is quite good, I think.
Yeah. Well, so if anyone is interested in trying to get some studies going or get some of that, depending on where you are, we may need a translator, but I think it would be wonderful to get. I do believe that this could really help anyone with asthma if they have access. Yes.
Is there any legal responsibility on the providers?
Great question, and I have spent more time than I care to with attorneys lately. So there is, in order to, and that's the question about can this be available to patients. So in order for a practice to use this application, there has to be a business associate agreement between my company and the practice. And that agreement basically states that we agree that I, as president of my company, have gone through the appropriate steps to ensure HIPAA compliance. So as far as patient protection and patient privacy and those kinds of things, there's a terms and conditions statement in the application that says this is not to serve as an alternative to medical advice. This is so there are legal protections in place for sure that protect both the patient and the provider in case something goes wrong. There's a way on the application that it can be accessed even without internet access. So it's not that you have to be connected to Wi-Fi or have internet access in order to get the instructions from the app. And that was something we had to work through. Yeah.
My concern is if your patient is in the red zone for 3, 4, 5 days and nobody is checking on that.
Right.
Is there a responsibility on the physician if something happens to this patient?
No, and that's something that's spelled out in the business associate agreement, that it is a tool. It's not a diagnostic tool, and so no, you would not be found liable that your patient didn't communicate. There's no liability there that says you have to contact your patient if they get in the red zone and that kind of thing. That there's protection for the provider there. Yeah. Great question. Yes.
Am I right that, if I understood it correctly, that the app will be available in the provider's office? The provider will give it to the patient?
Right. Well, so yes, the app will actually be on the App Store for the patients to download for free. I didn't want to charge the patients. I had issue with charging the patients for this. But if you as a provider are not affiliated, I mean, so if you don't have access to the web portal, the patient could have the app, but then that information wouldn't go anywhere. But they could still, I mean, they would have it. It just wouldn't, it would just be floating out in space, so there wouldn't be any communication between the patient and the provider. And I think that's the kind of the crucial piece, the crucial element in that. Because otherwise it's just translating a piece of paper onto a phone, and that's, you know, that's not what makes this helpful in my mind. So, great questions. Thank you, everyone. And if
Thank you very much.